Good morning. My name's Rob, and I'm going to show you how we used a simulation model to evaluate the impact of a pandemic vaccine in several different scenarios. The purpose of this exercise was to see what kinds of benefits might be achievable with a relatively limited supply of vaccine that only becomes available after the pandemic has already started. Once we have a reasonable idea of what we might expect to be able to achieve with a vaccine, we can then start to think about what it means to make best use of a vaccine. I'll show you an overview of the model in the next few slides, but first I'll tell you why this kind of model is useful. The primary advantage is that it lets us consider lots of different hypothetical scenarios before we experience an actual pandemic. This includes scenarios where we don't respond to the pandemic at all. Not because that's something we would ever do, but because it gives us a reference against which we can then evaluate all of our different strategies. By doing this, we can identify circumstances under which a vaccine program can achieve what we want to achieve. It also allows us to estimate the demand that will be placed on our healthcare system and the number of outcomes, such as hospitalizations and deaths, that might be prevented. And because we track the status of every individual in this model, we're also able to identify adverse outcomes, such as where a strategy might negatively impact a specific group in the population. Now, a model is always a massive simplification of the real world. We have to make lots of assumptions and limit our focus to a small number of key factors. And this means that we don't place absolute trust in the precise results obtained from the model. This can definitely sound confusing or vague. So I'll give you a brief example that should make this clearer. Let's imagine that you live in a large city, that you're currently at home, and that you're going to drive across town to an appointment that starts at 2 p.m. How do you decide when you will leave home and what route you will take? You might have a good idea of how long a normal route should take you if there's no traffic, so that's a starting point. And maybe you think that the traffic will add 10 or 15 minutes to your drive, in which case, perhaps there's an alternate route that would be faster. You might also think about whether you'll need to refuel your car on the way. So you end up choosing a route and a departure time based on these factors. You've ignored a lot of details to keep this decision relatively simple, and there are still circumstances beyond your control. But by using this mental model, you should have really improved your chances of arriving at your appointment on time. So now I'll show you the basic structure of our model. We start by assuming that all we need to know about each person is whether they are either susceptible to infection with pandemic flu, or if they've recently been exposed to it, or if they were exposed to it and now they have become infectious themselves, or if they've recovered from the infection and won't get reinfected. Because this is all we need to know about each person, we can just keep track of how many people are in each of these 4 different states, which we call S, E, I, and R for short. Everyone begins in S. People move from S to E when they encounter an infectious person. After a short delay, they then move to I and become infectious themselves, capable of infecting others. After another duration of being infectious, they then move to R and recover from the infection. And because this model is focused purely on how a disease spreads, death in this model is a form of recovery, simply because it means that the person is no longer infectious and cannot be reinfected. We then allow for susceptible people to be vaccinated, and we then move them from S into the SV compartment. We assume that this vaccination reduces their chance of becoming exposed should they encounter an infectious individual. Now, we actually divide the Australian population into a number of different groups so that we can give them different behaviours and attributes in this model. They all mix with each other, but they can do so with different intensities, and they can have different risks of developing severe disease. We start with 6 age groups that cover preschool children, primary school children, high school children, working age adults, and the elderly. We divide the primary school children into those under 10 and those aged 10 and older, because we expect that children under 10 will always require 2 doses of vaccine to receive complete protection. We then divide each age group into urban and remote Indigenous populations and the non-Indigenous population. We then further divide working age adults into several groups. We treat pregnant women as a separate risk group. We treat adults with comorbidities as a separate risk group. And then we have 3 key workforce groups who will be prioritized to receive vaccination first. In terms of how these groups mix, we assume that primary school children mix more intensively than other age groups because they're understood to be key drivers of the spread of infection. And we also assume that Indigenous populations have more intense mixing than non-Indigenous populations. We also assume that some of these groups are much more likely to experience severe disease if they become infected, and this is based on past observations. These groups, which collectively we'll call high-risk groups, include the Indigenous populations, children under 5, the elderly, pregnant women, and adults with comorbidities. Now, our focus is on the observable impact of disease and the burden that this will place on the healthcare system. So from our model, we obtain predictions of the number of people who will be sick enough to seek healthcare on each day of the pandemic. So we'll follow the healthcare pathways now that these people take so that we can measure these outcomes. So first things first, not everyone who is infected will develop symptoms and seek healthcare. Only a proportion of those infected will seek healthcare. Some of these people will be sick enough to require hospitalization, and we refer to these people as severe cases, while the rest we refer to as mild cases. So let's consider 2 people, Mary and Steve, where Mary is a mild case and Steve is a severe case. Both Mary and Steve may choose to visit their GP or visit an emergency department. Mary is a mild case, and so her journey ends here. Perhaps the doctor prescribes her some medication and most likely tells her to go home and rest. Steve is a severe case, so he will either be admitted to a general ward, or if he's extremely unwell, he will be admitted to an intensive care unit. If Steve is sick enough to be admitted to an intensive care unit, there's a chance that he may die. And it is these deaths that occur within the healthcare system that we can observe and which we can consider as being preventable. One final complication is that if there are enough people like Steve filling beds in hospital wards, this actually reduces the capacity of emergency departments to triage new cases and to admit the severe cases into the wards. In this model, we considered 3 different types of pandemics that might occur. And what we're showing here is the number of people who will seek healthcare at each day of the pandemic for these three different scenarios. Starting at the top, we have a low transmission scenario where the disease spreads very slowly. So there aren't huge numbers of people seeking healthcare on any single day. But over the duration of the pandemic, there can still be large numbers of cases in total. We're showing three very different epidemic curves here in red, blue, and green to highlight that there is still a lot of variability within each of these scenarios. In the middle, we have a moderate transmission scenario, and you can see that this is a more rapid event than the low transmission scenario, and that there will be a greater intensity of people seeking healthcare. And at the bottom, we have the high transmission scenario where disease spreads rapidly and the pandemic is over quite quickly. This will have a much greater impact on the healthcare system because it produces a large number of cases in a short period of time. The vertical grey dashed lines at 6 weeks and 12 weeks indicate the times at which we might expect to begin receiving pandemic vaccine. The main thing to note here is that the amount of time we then have to distribute this vaccine before the pandemic is over differs greatly between these scenarios. And so we'll see how this affects what we can hope to achieve with a vaccine in each of these scenarios. Based on discussions with the Department of Health, we assume that pandemic vaccine will arrive in batches of 3.4 million doses every 6 weeks, and that from this supply, we can deliver up to 750,000 doses of vaccine to the population each week. We assume that it takes 2 weeks to develop a protective immune response after being vaccinated, and that if a second dose is required, it will be provided 2 weeks after that person's first dose. We assume that 70% of people who are vaccinated will develop protection, and that this protection means that they are 70% less likely to become infected if they encounter an infectious person. If 2 doses are required to receive complete protection, we assume that the first dose gives you half of this protection. And finally, we assume that 5% of vaccine doses are wasted in that they don't actually end up being provided to people in the population. So now, this is just a reminder of who our high-risk groups are. So please keep them in mind as I show you the simulation results for our different vaccination strategies. We'll consider 2 different vaccination strategies here. For both strategies, we first provide vaccine to essential service workers. We then make vaccine available to priority groups until a certain proportion of them have been vaccinated. And finally, we make vaccine available to the general population. In both strategies, we continue distributing vaccine until we reach a final target level of vaccination in all groups. And these levels are roughly what we would expect to achieve in a really bad flu season. In the first strategy, our priority groups are the high-risk groups. So we're providing them with direct protection. Once a quarter of them have been vaccinated, we make vaccine available to everybody, and we assume that there will continue to be vaccine uptake in the high-risk groups. In the second strategy, our priority groups are primary school children, so we're providing indirect protection for high-risk groups by targeting the main drivers of transmission. Again, we then make vaccine available to everyone until we reach a final target level of vaccine coverage. So let's see how these 2 strategies compare. First, we'll look at how much the vaccine strategies can reduce the number of clinical presentations, the number of hospitalizations, and the number of deaths in the entire population. We measure these outcomes relative to what they would have been if we didn't provide any vaccine at all. The y-axis is a percentage, where 100% means that the vaccine resulted in no reduction in these outcomes. And so small values are better than large values. The results for the direct protection strategy are shown in green, and the results for the indirect protection strategy are shown in orange. In the low transmission scenario, both vaccine strategies greatly reduce the number of harmful outcomes, and the indirect protection strategy performs better than the direct protection strategy. In the medium transmission scenario, both vaccine strategies provide some reduction in the harmful outcomes, and the two strategies perform about as well as each other. And in the high transmission scenario, both vaccine strategies have minimal impact on these outcomes. Now we'll look at how many hospitalizations we can prevent in the high-risk groups as compared to the rest of the population, who we'll refer to as low-risk individuals. The y-axis here is the number of hospitalizations per 100,000 population, and the horizontal dashed lines show what these rates would be if we didn't provide any vaccine. The results for the direct protection strategy are again shown in green, and the results for the indirect protection strategy are shown in orange. In the low transmission scenario, both vaccine strategies greatly reduce the number of hospitalizations. Both strategies also reduce the risk of hospitalization for high-risk groups below the dashed line for the low-risk individuals. So in this scenario, both vaccine strategies can greatly reduce the risk gap between low-risk and high-risk groups. In the medium transmission and high transmission scenarios, the vaccine strategies have a smaller impact on the number of hospitalizations and on the risk gap itself. And so the use of a vaccine alone in these two scenarios won't deliver as much protection. We'll now look at how the dose requirement for people aged 10 and over might affect vaccine impact. We consider three cases. The first is where people over 10 only require a single dose to receive full protection. And that is what we've assumed so far in all of the results I've shown you up to now. The second case is where people over 10 require 2 doses to receive full protection, and we provide people with 2 doses. The final case is where 2 doses are required, but we only provide people with a single dose so that we can provide a smaller degree of protection to twice as many people. Here, the y-axis is the number of hospitalizations, again expressed as a percentage of the number that we would expect to see if we didn't provide vaccine at all. As we'd expect, vaccines have the greatest impact with a single dose requirement because that provides complete protection with the fewest doses. In the low transmission scenario, a 2-dose requirement slightly reduces the vaccine impact, but only providing 1 of 2 doses greatly reduces the vaccine impact. This is also true in the medium transmission scenario. It isn't true in the high transmission scenario, but that's because even with a single dose requirement, the vaccine has minimal impact in the high transmission scenario. So if 2 vaccine doses are required to receive full protection, we should expect to get better outcomes if we provide complete protection to fewer people, rather than providing partial protection to more people. If we look at the medium transmission and high transmission scenarios, you can see that this extra delay means that the vaccine has negligible impact on the harmful outcomes. But in the low transmission scenario, where the pandemic is very slow, we can still expect considerable benefits from both vaccine strategies, even with this delay. So to summarize these results, we saw that in the low transmission scenario, we can achieve a lot with a vaccine. It's capable of greatly reducing harmful outcomes for all population groups, and greatly reducing risk gaps between high-risk groups and low-risk groups. And the indirect protection strategy provides greater benefits than the direct protection strategy in this scenario. In contrast, in the medium and high transmission scenarios, we can't achieve these kinds of benefits with a vaccine alone. And there's likely to be little, if any, difference in outcomes between the indirect protection and direct protection strategies. So that's the end of my talk. Thank you very much for your time, and please feel free to ask questions.